Thank you. Well, September is Thyroid Cancer Awareness Month, and on behalf of the American Association of Endocrine Surgeons and the ThyCa group, I'd like to welcome everybody to this evening's webinar. I hope we're going to have an exciting discussion tonight about various aspects of thyroid cancer, the most rapidly rising cancer in the United States. Particularly want to thank Gary Bloom and ThyCa for helping us support this and provide questions for our panel of surgeon experts. ThyCa is a wonderful organization that helps thyroid cancer survivors. Obviously, anyone who has the diagnosis of cancer, even a cancer with excellent prognosis like thyroid cancer, is a very scary situation. There's a lot of worry, misinformation. Even though most patients do well, all of my patients are sure that they're going to be the exception who does poorly. And ThyCa has been a wonderful organization to help get accurate information to patients, both from other patients who have lived through this, and also to link patients to physicians with great expertise in this area. A little bit of background, I'm Allan Siperstein. I am fortunate this year to be president of the American Association of Endocrine Surgeons. This is our professional organization of surgeons who specialize in the treatment of endocrine disease and endocrine tumors. Thyroid obviously being most common. We deal with benign thyroid conditions and then patients with thyroid cancer. Our scope of practice typically is to evaluate patients with thyroid nodules, assist in the diagnosis, evaluate them for the proper surgical treatment, perform their surgeries, and then help them longitudinally in their follow-up. And so in tonight's webinar, we're going to go through a series of questions to deal with these various aspects of the disease process. So let me turn it over to our moderators for tonight, and we'll introduce the panel.
Great. Thank you, Allan. We'll just introduce everyone. I am Paul Graham. I'm an assistant professor in the Department of Surgical Oncology at MD Anderson Cancer Center. If everyone else wants to introduce themselves. Jenn?
I think we lost your audio, Jenn.
Sorry, can you hear me now?
Yes, perfect.
Okay. Jenn Kuo, I'm an endocrine surgeon at Columbia University.
Vikram?
I think I was muted for it. Vikram Krishnamurthy here, also an assistant professor and in the Department of Endocrine Surgery at Cleveland Clinic.
Dr. Parangi?
Hi, I'm Sareh Parangi. I'm one of the endocrine surgeons at Massachusetts General Hospital in Boston.
Great. And Dr. Zeiger?
Good evening, everyone, and thanks for joining us. I am Martha Zeiger, and I'm Director of Surgical Oncology, which incorporates endocrine surgery at the National Institutes of Health. We do research as well as surgical procedures for endocrine disorders. I'm also past president of AAES and currently president-elect of the American Thyroid Association. So many of us are part of all of these endocrine organizations that deal with and help patients with thyroid disorders.
Great. Vikram, do you want to start us off with some of the questions provided by ThyCa?
Yeah, definitely. So I think we're going to start with some basics just to describe the thyroid and what its function is and various conditions, including cancer. So just some basics about, what is the thyroid exactly for someone who may be hearing about, thyroid cancer, thyroid nodules for the first time. So maybe we could start with Dr. Kuo, if you wanted to take this question.
So the thyroid gland is a butterfly structured organ that sits in the neck, and its main job is to produce thyroid hormone, which has a prominent role in many different functions of the body, but largely metabolism.
And when people develop thyroid nodules or say they have a mass on the thyroid, what are they talking about? Or can you walk them through a little bit more information about how that is in the thyroid? We often get questions about what the nodule is. Is it in the thyroid or on the thyroid, and what we're dealing with?
So thyroid nodules are areas of excess growth within the thyroid gland. Often patients think that they're kind of hanging fruit off of the organ, but they're actually within the thyroid gland itself. And most of the time, these nodules are benign. A lot of patients will have them. About 65% of the general population will have thyroid nodules. But 5% on average will have thyroid cancer.
Yeah, to build off that too, I think a lot of times when we talk to our patients about thyroid conditions, we have to explain to them, you can have problems with function of the thyroid, meaning overactive or underactive, and then you can also have a problem just with the structure, which is completely unrelated to function. And those are exactly like the nodules Dr. Kua was talking about. Dr. Siperstein, would you like to talk about when patients may ask you exactly how these nodules develop? Was it something that they did? Is it something they could prevent?
So there are many different reasons for the thyroid to enlarge, and the generic term that's used for any type of thyroid enlargement is goiter. Historically, iodine deficiency has been responsible for overgrowth of the thyroid, and in most cases, these are entirely benign. When cancers develop in the thyroid, in general, there is not a specific cause. It's nothing the patient did, then nothing the patient didn't do. In decades ago, people used to receive treatment doses of radiation to the neck for various reasons. We don't do that anymore. That's one of kind of the identifiable historical causes of thyroid cancer that we know of. But most cases, we don't know what the underlying cause is. It's just one of those random things that happen.
So when you get a diagnosis of a thyroid nodule, when does the patient need to know about that, and what do they need to do next with that? Dr. Zeiger?
Great question. Generally, when patients have a thyroid nodule diagnosed, they probably have another underlying thyroid disorder. That's why they had it diagnosed. Either someone felt the nodule or someone saw the nodule with an ultrasound. If it meets criteria for biopsy, in other words, if it's not perfectly benign on ultrasound, we do recommend doing a fine needle aspiration to be certain that it's benign. If it's suspicious or indeterminate, or if it's malignant, then patients should be referred to a specialist, either an endocrinologist and or to a surgeon for surgical excision. But in general, start out with physical exam, then an ultrasound, and if there's any concern, a fine needle aspiration biopsy.
Dr. Parangi, would you like to comment on when patients come to you ask you about whether or not they can live without their thyroid, and what might happen if they end up taking thyroid medication and missing a dose?
So that's a very common question that patients ask, especially if it becomes obvious that they will need thyroid surgery. The good news is that the thyroid really, in terms of body function, is essentially just making one very important hormone called thyroid hormone. That hormone is essential for the function of the body, but luckily for everyone, it's replaceable by a pill and has been for many years. And so essentially, if the entire thyroid is removed, then the patient would have to take thyroid hormone. It's an easy pill to take. They take it every day, usually first thing in the morning, and their endocrinologist can then assess how happy their brain is. So the patient's brain is able to tell the endocrinologist with a certain hormone called thyroid stimulating hormone level in the bloodstream, how happy the brain of that patient is with the thyroid hormone levels. And once that's done as a blood test, it can be monitored and titrated almost to perfection, to a very good level that will keep the patient happy and healthy and able to metabolize normally. So I think while patients fear certainly having to take any medication, especially if they're not used to taking medication, it certainly seems from from my experience and the wonderful endocrinologists that we work with, that the vast majority of patients have a good experience with thyroid hormone. Luckily, these days, for many thyroid conditions, nodules, or even cancers, we don't have to remove the entire thyroid hormone. So not everybody has to take thyroid hormone. But I think if you do have to take thyroid hormone as a patient, it's best to have an experienced person work with you on the dosing, and almost always you'll have a good experience.
Dr. Kuo, Dr. Zeiger had mentioned, if you have a thyroid nodule that looks concerning, that it leads you down the pathway of potentially an ultrasound and a fine needle aspiration. Can you talk a little bit more about what a fine needle aspiration is and what patients can maybe expect as results from that?
Excellent question. I get this all the time. So fine needle aspiration biopsies, where we use an ultrasound to guide placement of a very thin needle, usually thinner than what the needles that we use to draw blood. And we use the ultrasound to place that needle directly into the thyroid nodule itself, and we collect cells from the thyroid nodule. These cells then get smeared on a slide and looked at under a microscope by our cytopathologist. And from the way that the cells look and how they are arranged with each other, our cytopathologist will have a good estimate of whether or not those cells represent cancer.
Dr. Siperstein, would you just like to comment on what resources are available for patients who may have just got a new diagnosis of thyroid cancer?
Sure. Well, so step number one is kind of what is the certainty of that diagnosis? And we've been talking about needle biopsy of the thyroid. In an ideal world, the diagnostic test would tell you it's 100% benign or 100% cancerous. But unfortunately, thyroid cancer cells, benign cells can mimic cancerous cells, vice versa. And so step number one is to figure out what the certainty is that we're dealing with a cancer. There's a grading system that the cytologists use. It's called the Bethesda scale. And at one extreme of that scale, you're very certain something's benign. At the other extreme of that scale, you're very certain, almost 100%, that it's cancerous. So you know you're dealing with a cancer diagnosis. And then there's a gray zone in the middle. And we divide this up into 3 shades of gray to make things even more complicated. And each of those shades of gray has an increasing risk of the nodule being cancerous. So one of the discussions based on the size of the nodule, its appearance on the ultrasound, exactly what the reading is along this scale, the discussion is, what is the chance of this lesion being cancerous? In the more modern era, and we'll certainly have some more discussion on this later on, we can do some fancy molecular testing, DNA and RNA testing, to help us be more or less certain that a nodule is cancerous. So in an ideal world, we're bringing the patient to the operating room with a 100% chance that it's cancer. In other situations, because of the fact that the benign cells and the malignant cells can overlap with their appearance, we have a somewhat more difficult, complicated discussion with the patient, stating that, well, there's a 50% chance or 70% chance that we're dealing with a cancer, but we can't be certain. On the other hand, many of those things that are not cancerous today, they may come back officially benign, may have the potential to become cancerous later. So those lesions also would need to be removed. So this is depending on the detail of, as I said, what the lesion looks like and what the needle biopsy result comes back, there'll be a discussion about, risk of cancer, which will then determine whether surgery is needed, and importantly, what the extent of that surgery is. That is, how much of the thyroid is removed.
Thank you. Dr. Parangi, so say they do get a biopsy result that comes back with thyroid cancer. We often get told, at least I have the good kind of thyroid cancer, or a good kind of cancer, the thyroid cancer, but is all thyroid cancer the same, or are we talking about different things?
So there are multiple different kinds of thyroid cancer, and the different kinds that exist in the thyroid Most of them generate from the same original kind of thyroid cell, the kind of thyroid cell that makes thyroid hormone, which is 99% of the cells inside the thyroid. So the most common kind of cancer that we see in the thyroid is papillary thyroid cancer. And that is, relative to other cancers, a better cancer. Now, in my experience, most patients don't come in with that attitude. They don't say, great, I have cancer, I'm gonna be just fine. Most are scared, most are worried, most do not like the C word, and they worry that they're not gonna see their children or their grandchildren. And so I think in my experience, what I try to do is reassure the patients that yes, papillary thyroid cancer especially, specifically, has very good long-term survival. And sure, there can be some outliers, some patients who have either very big tumors that were detected unfortunately late, or they have very specific subtypes, rarer types. So yes, most patients with papillary thyroid cancer, which is the most common kind of thyroid cancer, do better than other cancers. Now, there are also other kinds of thyroid cancer. There's follicular thyroid cancer, and then there's poorly differentiated, which is a little bit of a worse player. And then there's anaplastic thyroid cancer, which is again from that same cell, but seems to behave much more aggressively and spreads rapidly. And unfortunately, patients with that rare kind of thyroid cancer do very poorly. And there's a lot of research going on how to improve that. Fortunately, that kind of cancer, anaplastic thyroid cancer, is very rare. So we're lucky with that. And then there's a different cell in the thyroid. So about 1% of the cells in the thyroid are actually, kind of neural cells, almost kind of like nerve ending cells, and they're inside the thyroid. And that kind of cell, when it becomes cancerous, is a totally different ballgame. That's called medullary thyroid cancer. And it is a cancer, and it behaves as a cancer, and it is growing from inside the thyroid, but it is a little bit of a different kind of thyroid cancer. So generally speaking, those are the kinds of thyroid cancers patients see. Very rarely patients can have growths in the thyroid that are cancerous, but actually come from a different site. So for example, if a patient had a melanoma resected, or a skin cancer, or a kidney cancer many years ago, occasionally a seed of that will have settled in the thyroid and grow later. But most of the thyroid cancers we see are papillary thyroid cancer.
Yeah, thank you for that, Dr. Parangi. And so I know we all see patients with thyroid cancer, and we like to highlight how good the prognosis is, but it is also important to recognize, of course, there's a whole lot of financial, economic, socioeconomic stresses that go along with any sort of medical condition that requires surgery and follow-up. So we're certainly sensitive to our patients, not wanting to hear that they have a quote-unquote good cancer or bad cancer, because it's all very stressful for them. Before we move forward kind of further into kind of the more advances in diagnoses and treatment, Dr. Poe, do you want to talk a little bit about how common thyroid cancer is, and like Dr. Siperstein touched on, why we may think we're seeing more and more of it?
Sure. Okay. So thyroid cancer is pretty common. It's the 6th leading cause of cancer in this country, and estimated to be the 3rd leading cause of cancer in women by next year. About 1% of all Americans will develop thyroid cancer in their lifetime. So we have seen increasing diagnoses of the thyroid cancer over the last few decades. It even made it as an editorial in the New York Times back in 2016, I believe. And a lot of it has to do with advances in medical technology. So ultrasound has been mentioned several times during this discussion already, and it plays a very crucial role in thyroidology. When it was introduced back in the 90s, real-time ultrasound, we started to be able to diagnose these thyroid nodules at very, very small sizes. When before, thyroid nodules were really only detected when they got large enough to be felt on a physical exam. So when you look at the rising incidence of thyroid cancer in the last couple of decades, it's really been an increase in these small papillary thyroid cancers, less than a centimeter in size, what we call micropapillary carcinomas. And that's really what is accounting for the large increase in thyroid cancer over the last few decades. The thing to know about microcarcinomas at this point in time, after several large observational studies conducted mainly in Asia, is that oftentimes they don't grow and they don't cause patients any problems until they get over 1 centimeter in size. And so whereas we were treating all thyroid cancers before, we have actually, the pendulum has now swung to the other side, and we're becoming less aggressive in treating these very small, indolent cancers that really have questionable impact on patients.
Thank you for that. So, Dr. Zeiger, if someone does come up with a new diagnosis of thyroid cancer, and when we talk about cancer, we talk about staging disease and kind of knowing the extent of it. Could you talk a little bit about what we do for thyroid cancer and evaluating maybe the extent of disease? We'll see about unmuting your microphone as well.
Sure. So when someone has a diagnosis of thyroid cancer, they should have a neck ultrasound where we look at the lymph nodes in their neck, the right side, left, both sides of their neck, as well as the middle of their neck, to see whether or not there's evidence of spread. Because if there is evidence, then the patient should have a neck dissection at the time of thyroidectomy. So we determine the extent of surgery based upon what the ultrasound shows. Oftentimes, a patient will need a second biopsy if they have a suspicious lymph node in their lateral neck, their neck on the side. If they have a suspicious node in the middle of their neck, we don't generally have to biopsy it because we're going to be there surgically and it's unnecessary. If someone has fairly advanced disease, either a big tumor or evidence of a lot of lymphadenopathy, large lymph nodes, we generally recommend getting a CAT scan of the neck. It gives us just a better anatomical view of what's going on. Certainly, anybody with even more extensive disease might need a CAT scan of their chest if it extends down into their chest. But those are the two diagnostic tests that we use prior to surgery, mainly to provide a map for us and help us decide what kind of operation the patient should have.
Thank you for that, Dr. Zeiger. Dr. Parangi, can you talk a little bit more about additional imaging like PET scans for patients who have thyroid cancer? Is that something that most patients would need to get?
So that's a great question. I would say if a patient has a known thyroid cancer, and in those cases, when they will, be considering surgery, there's a couple of important things that the surgeon needs to know before going in. One question is, are lymph nodes involved? And ultrasound is, generally speaking, the best test for telling us that. Occasionally, if there's a big burden of disease, lots of lymph nodes, we may get a CAT scan to see if there could be lymph node disease, for example, further down in the chest area. But generally speaking, ultrasound has no radiation, is very safe to do, and doesn't delay treatment. It's easy to get. So most of us use ultrasound only. Occasionally, patients either have very advanced disease when they come to see the surgeon, or they have a rarer kind of thyroid cancer where we worry that it could have metastasized to other sites. And in that case, we sometimes do employ CAT scans, MRIs, or PET-CT scans. The PET scans pick up tumor cells that are using up glucose at a higher rate compared to normal cells, and that shows up as a bright spot. But PET scans are not necessary in 99% of patients with thyroid cancer.
Thank you. So Dr. Siperstein, so now that we have a diagnosis of thyroid cancer, patients been evaluated for possible signs of spread to other areas or the extent of disease. Tell us a little bit about how we would treat kind of our more common thyroid cancer, papillary thyroid cancer.
Thank you. Yes, and again, this is often a very detailed discussion with the patient because there are options in terms of the extent of surgery. Most notably, would the patient be a candidate to only have half the lobe taken out, half the thyroid taken out, that is the lobe that contains the cancer, or does it make more sense to remove the entire thyroid gland? And the way I think about it is there are 3 steps in the evaluation of the patient where that decision is made. First is the decision in the office conversation. So for example, if a patient has a relatively small cancer, it appears contained within the thyroid. We don't see evidence preoperatively of spread to lymph nodes. Also importantly, the other lobe of the thyroid looks pretty normal, because if there are nodules in the other side of the thyroid, those could potentially be cancerous or need evaluation before making this decision. But in the simplest possible case, if the tumors are relatively small and roughly about 4 centimeters or less, all other things look good, the more common operation today would be to just take out half of the thyroid. If things are other than that, more aggressive, then most surgeons would plan to remove the entire thyroid gland. And patients may ask, well, my other lobe is perfectly normal, why do you want to take it out? And the reason is, and I'm sure we'll be discussing these in more detail, that the most important next treatment for many patients is to receive a treatment with radioactive iodine. The thyroid is interesting in that it's the only cell in the body that concentrates iodine. And if you give the patient a high dose of radioactive iodine, individual tumor cells will actually concentrate it enough to kill them on a cell-by-cell basis. The normal thyroid tissue, if it's left in place, acts like a heat sink and will suck up so much of that iodine that it doesn't go to the tumor cells. So that's the reason you need to take out what otherwise would be a normal thyroid lobe. So again, there are a lot of different variables that go into this discussion in terms of how much of the thyroid to remove. The second time in the management where this decision can be made is in the operating room. So we may have a discussion with the patient that preoperatively everything looks fine, get into the operating room and unexpectedly, for example, find lymph nodes that are involved with cancer. So in that case, yes, the patient would need an iodine treatment, so we would go ahead and take out the other half. The third time that discussion can go on, unfortunately, and this is what we want to avoid, is when the patient comes back for their follow-up visit, we get the final pathology report back, and it turns out that what we initially thought was a low-grade, non-invasive type of cancer turns out to be more aggressive, or there are other features on the final pathology report where we say, yes, unfortunately, you will need the radioactive iodine treatment, and unfortunately, then we need to go back to the operating room and take out the other normal half of your thyroid to allow you to get that treatment. So there are kind of 3 steps. It's in the office before we operate, where that decision is usually made, but obviously occasionally in the operating room or when the patient returns for their postoperative visit, then we've reached our final decision in terms of the extent of surgery. Again, not a simple one-line discussion. It requires a lot of different factors to go back and forth with your surgeon.
Thank you for that, Dr. Siperstein. And we want to thank all of the audience members that are watching along on Twitter or Facebook, and we will try to get to all of your questions and try to fit them in where they may be appropriate. To backtrack a little bit back to thyroid cancers, the different types and how they're diagnosed, there's a question from one of our audience members that wants to know about any studies that have linked papillary thyroid cancer to any hereditary syndromes, and how we counsel maybe patients with multiple family members that have papillary thyroid cancer and what we know about that right now in this day and age. I will get that, Dr. Zeiger.
So there are specific criteria for people to be considered having familial papillary thyroid cancer. They need to have multiple family members who have papillary thyroid cancer. Unfortunately, at this stage, we do not know the exact etiology. We haven't found that specific genetic mutation or that specific abnormality that is associated with papillary thyroid cancer, like some of the other familial cancers. We do know, however, medullary thyroid cancer can be associated with a familial abnormality. It's called a mutation in the RET gene, R-E-T. So we are familiar with that, and certainly if we see someone with medullary thyroid cancer, we'll test them for that mutation to be certain that they do or do not have some sort of hereditary disorder. So it's something that many scientists around the world are working on, but as of yet, we do not have the answer. Most likely lies in something in our genes that are different than the straightforward mutations that we normally associate with other cancers.
And to follow up on that a little bit, so often we'll have a patient that's diagnosed with thyroid cancer and ask, should their family member be screened or should they have their family undergo an ultrasound? Any thoughts from anyone in the of our panelists on that?
Yeah, so this is an area that we've been scratching our heads on for 30 years, and I think you're absolutely right that most families, if one person has it, a relatively unusual cancer, yes, it's generally random or sporadic. You get 2 or 3 family members, you obviously realize that there's some familial association that we don't quite understand, and the current recommendation would be to do screening ultrasounds on other family members. There are a couple extremely rare conditions where we do know that there's a genetic association with papillary thyroid cancer. There's a syndrome of multiple colon polyp and cancer, something called familial adenomatous polyposis, and that condition is associated with thyroid cancers. And then there's an extremely rare condition called Cowden syndrome that's associated with a lot of female reproductive cancers and breast cancers that's also associated with a high risk of thyroid cancers. But these are a couple of the very rare exceptions, and in most cases, as Dr. Zeiger very nicely talked about, we really don't know what the genetic link is, and so we're left with doing just a more primitive screening ultrasound.
Thank you for that, Dr. Siperstein. So moving into actual treatment of thyroid cancer with surgery, we talked a little bit about extensive surgery, removing the lobe versus the entire thyroid and lymph node dissection. Dr. Kuo, would you like to talk a little bit about the complications or potential complications following thyroid surgery and what the patient can expect?
So luckily, surgery for thyroid diseases is relatively straightforward. Most of the time it's performed as an outpatient operation. Just like any other surgical procedure, there's going to be very small risk for bleeding and a very small risk for infection. The more specific complications that can happen with thyroid surgery is injury to the nerves. There are 2. We most commonly worry about the recurrent laryngeal nerve, which innervates the vocal cords, but there's also the superior laryngeal nerve that helps patients reach that higher pitch in their voice and can affect singers. And then there's also concern for injury to the parathyroid glands, which are 4 separate little organs that sit next to the thyroid gland and control the calcium levels in our blood. If those organs are disturbed enough during the surgery and injured and fail to function appropriately, then patients can have low levels of serum calcium levels in their blood. And
though the complications may be rare, and if they do occur, is there anything that can help the patient with them? Is there any additional treatments or medications that patients can use?
So for patients with nerve injuries, most of the time their voice is going to be hoarse in the initial recovery period. Usually, with just time, actually, the voice can improve quite a bit, lots of times to their, almost to their baseline in terms of speaking voice quality. There are some medications now that we know can potentially facilitate and expedite the recovery of the nerve. Sometimes our voice specialist can do a Botox injection to the vocal cord during the most symptomatic time period to help relieve the symptoms that the patient may be experiencing during that time. With regards to hypoparathyroidism and the low calcium levels in the blood, a lot of times that's temporary and can be managed as an outpatient with intake of calcium and sometimes vitamin D, both in its inactive and active forms. In very, very severe cases, there is a medication now called Natpara, which is an injectable form of parathyroid hormone. But it is very, very expensive and not accessible to a lot of our patients.
Thank you for that, Dr. Kuo. So once again, we'd like to thank the audience members that are watching this feed for their questions and welcome to answer. Ask any questions as we are kind of winding down here towards the end of the session. We're going to continue going forward with the questions that were provided to us by ThyCa, but of course, if there's anyone out there in the audience that has any questions or comments, please feel free to add them in. Kind of building off what we talked about with complications and how thyroid cancer surgery for thyroid cancer is generally very safe. What about, not just talking about sort of the scary things about complications, but even just sort of about recovery and what patients can expect as far as, the actual operation itself, whether they stay in the hospital or how long they have to stay, if at all, and even what recovery is like. If you maybe want to talk about that, Dr. Parangi?
Sure, I'm happy to talk about that. I think generally speaking, the recovery from thyroid surgery of any kind, be it for cancer or just for benign disease, is very straightforward. Many times the patients either stay in the hospital until the early evening, usually 4 to 6 hours after the surgery, or if it's a little bit more expensive surgery, we'll stay overnight in the hospital and be able to go home the next morning. Many surgeons don't even recommend pain medicines for their patients because it's a procedure that actually patients remarkably have very little pain. We don't cut through any muscles, we just move the muscles around gently. And so they usually end up just needing Tylenol or Advil or Motrin. The recovery is anywhere from 1 to 2 weeks, depending on how the patient themselves is doing. During that period, we want the patients to be active, but not too active. So no weightlifting or doing anything really kind of over excessive, but we want them to be up and about, doing, maybe their regular movement, walking the dog. Activities are very good during the healing period. You do not want to be laying around in bed. And many people feel that they could go back to work anywhere from 1 to 2 weeks after surgery. And that's very dependent on what kind of work the patient does. And I think, in general, my own experience and recommendation to patients is this is a good time to rest and relax so that your body can put energy into healing and, not necessarily focus on work. But if you have to do some work, then, that probably would be okay from home. But I did want to get back to the little issue about complications, because I think there was a question about that, about the if the calcium sensing glands, the parathyroids, are, hurt during the surgery and never work again, which is rare, but can happen. And patients end up having to take that injectable Natpara that Dr. Kuo talked about, which is very expensive. That's currently not available. It's been stopped by the FDA because there were some small, tiny rubber products in the injectable solution. So there was a question from an audience member listening about what happens if patients need that and they can't get it. Well, there are some special forms of vitamin D that are very potent, and usually if you give patients higher doses of vitamin D, that potent kind of vitamin D called calcitriol or recalcitrol, combined with higher doses of calcium carefully and really get it right, you usually can manage almost everybody with those two medications. And then, of course, people are doing research on parathyroid hormone, and even doing some research on stem cells to develop new therapies so that people can maybe someday transplant stem cells, which will produce parathyroid hormone. So there is hope for that. But most patients recover without complications and do well.
And Dr. Siperstein, often our patients will read about using a nerve monitor during surgery to avoid complications to the recurrent laryngeal nerve. Can you talk a little bit about what that is, what that helps us with, and its use in thyroid surgery?
Yeah, so the nerve that's being looked at is the recurrent laryngeal nerve, the one that we've been talking about primarily, that works the vocal cords, that helps you to speak. And a nerve is analogous to an electrical wire where an electrical signal goes down it. And so the technique of nerve monitoring involves putting a special endotracheal tube, that's the tube that the anesthesiologist puts down the windpipe during the surgery, and that has electrodes attached to it. And then at the time of the surgery, an electrical signal can be applied to the nerve when you identify it, and you can then trace the conduction of that electrical signal into the tube, and it tells you that the wire is intact. If the nerve has been injured or cut, that signal won't transmit anymore. Sounds great in theory. In practice, there are a lot of technical factors that may give you the false impression that the nerve is working or the false impression that the nerve is not working. In terms of large studies that have been done, they have not overwhelmingly supported the use of nerve monitoring. It's the question is experience in identifying where the nerve is, minimally dissecting it and staying away from it, a safer strategy than having to do more dissection and a manipulation of the nerve, test its electrical conductivity? Is that in itself going to be more damaging? I guess a middle road that many of us employ is that of selective nerve monitoring. So if we have a relatively routine case, we rely on our experience to identify and stay away from it. Sometimes we have a more complicated case. For example, we have a cancer that may look like it's invading into the area of the nerve, or it's a reoperative situation where they've already had an operation and we're going back in and there's scarring in there that can obscure where the nerve is. Those are selective cases where nerve monitoring may be helpful. So again, it's one of those areas to discuss with your surgeon, their pros, their cons. There's no absolute right or wrong answer to that.
Thank you, Dr. Siperstein. So kind of moving in, segueing from complications into choosing a surgeon, something that we all know about or talk about as surgeons is called volume outcomes, which may not be a term that's familiar to patients. But one of the concepts we talk about in all surgeries and procedures as far as reducing the risk of a complication for our patients is seeing a surgeon that has specific expertise in that area or performs a lot of a certain operation a year. So I have a two-part question for our panelists. Dr. Zeiger, would you talk a little bit about surgical volume as it's related to thyroid surgery and potential outcomes and complications for patients? And Dr. Krull, as someone who's written extensively on this, could you talk a little bit about what defines an endocrine surgeon as compared to another type of surgeon, and where patients may be able to find resources if they're interested in having a consultation with one?
Sure, that's a great question. So I think the most important thing is that the patient find a surgeon who focuses on thyroid and parathyroid surgery. The way to do that is through their referring physician. So either their primary care physician or their endocrinologist often will know who the local surgeon is who's very experienced in this area. It's perfectly reasonable to ask the surgeon how many surgical cases they do a year, how many thyroid and parathyroid surgeries they do a year, and what their complication rate is. We would expect someone who is expert to be doing anywhere from a minimum of 50 to 100 such operations a year. They can be a head and neck surgeon. They can be an endocrine surgeon, which all of us are on the panel. An endocrine surgeon is someone who trained in general surgery, but then went on to get additional training in endocrine surgery. So this is what we focus on. But the most important thing is make sure that you research the surgeon. The surgeon is experienced. The surgeon has excellent results. And don't be shy. This is your life, your health. It's quite reasonable to ask all those questions.
Thank you for the question with regards to what is the difference between an endocrine surgeon and an ENT. As Martha mentioned, endocrine surgeons come from a whole variety of training backgrounds. So we come from general surgery, we come from surgical oncology, and also otolaryngology. But an endocrine surgeon is really someone who has dedicated their practice to surgical treatment of endocrine disorders. Whatever training background they come from, they are invested in the disease process. They understand the disease behind the patient's problems, and they understand the surgical treatments for those diseases. The American Association of Endocrine Surgeons have endocrine surgeons that come from general surgery, that come from otolaryngology, they come from a surgical oncology background. But the one common thing is that we have dedicated our practice to this field. So because of that, we're able to counsel patients not just on what the details of the surgery is going to be, but what the physiology of the diseases are behind those problems, and what may be the treatment options that are best available to them.
And Dr. Siperstein, can you elaborate a little bit on kind of how we are training the next generation of endocrine surgeons and the role of our society in keeping that good outcome up?
Yeah, happy to. So endocrine surgery, and particularly thyroid surgery, is interesting in that it has evolved very rapidly. The diagnosis of thyroid disease has rapidly evolved. Interpretation of needle biopsies, the indication for surgery, how much surgery do you do, how things are staged, what treatment and follow-up do you need afterwards. These are things that have changed dramatically even over the last decade. And so I agree entirely with what my colleagues have said, and that the patient should really seek out somebody who has specialized training and expertise in this area. The American Association of Endocrine Surgeons now for over a dozen years has developed fellowship training programs specifically to train the next generation of general surgeons who are then interested in specialty training in this area. And it's a very rigorous curriculum. There are 24 prestigious institutions around the country that have these fellowships. There's a rigorous educational curriculum and with obviously very high standards. And the wonderful thing about this is we now have half a generation of surgeons out there who have specialty training, are dedicated to this area, who stay up to date in the latest of technologies, and then very importantly, as Dr. Zeiger pointed out, do a high volume of cases. You want to seek out a surgeon who does this operation very frequently and is very familiar with all the little subtle changes in anatomy and things to look out for so that your outcomes are optimal. I mean, we overall talk about relatively low complication rates. Well, we're really talking about the high volume experts. If you look at the complication rate of surgeons who do this in lower volumes, and we have studied this, unfortunately, the complication rate in terms of nerve injury or permanently low calcium values starts to go way up.
Good back, Dr. Siperstein. And so, sort of to build off that and answer one of our audience members' questions, the particular question was how do individuals find an endocrine surgeon, and what should they do if they don't want to have one in their area? A couple answers and comments on that. Our website, the American Association of Endocrine Surgeons, does have a surgeon finder where you could type in your location and they will give you a list of people in the area. Fortunately, the expansion of endocrine surgeons, both old and new, is increasing across the country in both academic practices in large cities and into the suburbs, and even hopefully into some rural areas too. So you may be able to find one in your area if maybe there was not one before. And then Dr. Parangi, would you like to maybe talk a little bit about the option of these external resources available for second opinions? If a patient maybe wants to just get a second opinion about their case, what is available to them currently?
Yeah, I guess what I would say is if you're a patient and you need thyroid surgery, or if you are a patient who's had thyroid surgery and you need more thyroid surgery, you had a recurrence or there was an issue, it never really hurts to get a second opinion. Often patients will say, I feel like I would offend my original surgeon who I sought a consult with if I get a second opinion. And that's very far from the truth. A good surgeon, a good physician, a good endocrinologist will always be happy if their patient seeks a second opinion, because they have confidence and they know that you are just trying to do due diligence and make sure that you're getting the best care. So if you can get a second opinion from an experienced person, it usually will be very helpful to you. Even if you trust the original surgeon and go back to the original surgeon, it will give you often a lot of additional information and really a second pair of eyes looking at everything, make sure that all the I's are dotted and T's are crossed. Unfortunately, the U.S. is very big, so an experienced surgeon may not be very close to you, and so getting a second opinion can be difficult. There are lots of online platforms now that provide second opinions, and certainly I know I've provided probably 25 to 30 second opinions via these online video consultations. They gather your information, usually nurses, and then they provide it to an expert who's signed up to accept these. And then the expert reviews it and either sends you some comments or actually chats with you. And so that's another way you could try to get a second opinion without the expense of traveling far away.
Thank you very much. So to change topics just a little bit, getting back to after treatment with thyroid cancer, you see our patients back, they've had surgery, they kind of asked what's the next step after surgery in terms of either additional treatments, as we alluded to a little bit earlier, or in terms of long-term surveillance for their thyroid cancer. Dr. Quo, can we start with you?
So if additional treatment is needed as in addition to surgery, then it would be radioactive iodine, which Allan had talked about earlier. And this is all thyroid cells, whether they're malignant or they're benign, love iodine. And so we can attach a radio tracer to the compound. It's a single pill that patients would take, usually around 2 months after surgery, once they have healed appropriately from their operation. And the iodine travels to any remaining cells that may be floating around in the system, and the radiation kills it. It's a very good treatment for thyroid cancer, and it works much, much better than traditional chemotherapy does for thyroid cancer. For those patients who don't need radioactive iodine ablation, or who do, actually, ultrasound as well as following blood marker called thyroglobulin, which is a protein that any thyroid cell can make, is going to be routine, at least for the first 5 years, if not longer, after their operation, just to make sure that the thyroid cancer hasn't come back.
Thank you, Dr. Kuhl. Dr. Siperstein, could you comment about, overall the general prognosis, which you kind of mentioned earlier on, but specifically about the percentage risk of thyroid cancers coming back for a patient, so the risk of recurrence, and what kind of determines that and how we prevent that from happening beyond radioactive iodine?
Thank you. Like all cancers, they're staged. And what we mean by cancer staging is we look at the characteristics of that cancer that predict their recurrence. So it has to do with the size of the cancer, whether it's invaded, has it spread to lymph nodes. So these various factors we use to predict the risk of something coming back. What's interesting and often doesn't follow common sense and doesn't follow other tumor types is that even if thyroid cancer spreads to the lymph nodes, and it does relatively frequently, it really does not dramatically alter the long-term outcome or prognosis. And most of what we're talking about prognosis is the risk of recurrence. The risk of death for most thyroid cancers is extremely low. So with most patients, the discussion is not whether you're ever going to die of this, because the odds of that are extremely small, but what are the odds for the remainder of your life that this cancer is ever going to come back? In most cases, if the cancer recurs, it comes back to lymph nodes in the neck, either immediately next to where the thyroid was, or in the next lymph node compartment called the lateral neck compartment. If that were to happen, it requires another operation to remove those lymph nodes, and to a large degree, the clock gets sent back to kind of your original prognosis or outcome. If patients are found to have spread to other sites, for example, the lung or bones or other places, fortunately, in most cases, it's relatively slow growing, can often be watched and monitored over time, and typically for a patient's lifetime never causes any problems. For the occasional case, and we're talking about the minority of cases, if things are very aggressive and growing rapidly, there are other types of chemotherapy, and this area is rapidly advancing to direct treatment against these more unusual but more aggressive types. And any visit that I have with the patient in follow-up, there's always a discussion in terms of what their lifetime risk of ever having recurrent disease is. If we see a patient back, if their exam is unremarkable, they have no lymph nodes, this tumor marker that Jenn described, thyroglobulin, is very, very low, then their lifetime risk of recurrence can be a very few percent, low single digits. And those are the conversations we like to have with our patients.
Thank you. Well, I think it's a good last question, kind of highlighting kind of the importance of treatment from start to finish. Dr. Siperstein, we'll just ask you for a few final comments, a little bit more on where patients can get additional research and resources for education, where they can find an expert in the field. Again, we want to thank our supporters, especially ThyCa, who supported us with the questions and also supports our association with research grants. Dr. Siperstein.
Great, thank you very much, and thank you to all the panel, and again, thank you very much to ThyCa. In terms of looking for patients to look for information, I think the answer is go to reliable sources. ThyCa has a wonderful website with a lot of resources. The American Association of Endocrine Surgeons and the American Thyroid Association all have websites with very detailed, I think, accurate information. I would encourage patients to stay away from a lot of the patient chat groups out there. I read those myself, and I often shudder when I see what's on there, because the patients can get widely disparate information that when I look at it, I said, oh, my patient is just going to get scared. They're going to be going off on some tangent. So again, unfortunately, the internet has a lot of misinformation, and I would encourage patients to look at reliable sources. And again, reach out to your medical endocrinologist, or reach out to any of us or other members of the American Association of Endocrine Surgeons. As Sareh said, Very often we can provide virtual visits or video chats or review of medical records for opinions. So gather complete and reliable information. And I think the other thing to emphasize is that rarely do you need to make an emergency decision about thyroid surgery, that it's always best to sit back, gather all of your information, and for the patients to feel very comfortable with any treatment decision that they've made. So again, I appreciate everybody's participation tonight, and I hope this has been a very interesting and useful chat to our patients out there.